but it really wouldn't always take place during like the spring months. But during the winter, everybody, it was almost like they were getting their bodies ready for like the springtime prime time. So I just, wanted to make mention of that because I know we've kind of touched on just celebrities and things. And I've just always found that to be really interesting how in certain schools, especially schools, and I can only reference LA because I grew up there are performing arts schools where that's like a cultural thing within the school that's what's happening. And I just think that, as counselors, I just kind of wonder how different would it be if I were to go back there and be like one of the counselors there, because I've kind of paid attention to it, like how I could connect those dots. Is something, I often think about. So I just wanted to share that.
Oh, Jill, I appreciate that. And I'm going to say very quickly, because the recording started late, you are Jill Ballesteros-Bowman. You are going to be leaving lately in a few minutes, but you are our CES student who introduced us. Dr. Bohrer, Dr. Rush Wilson. We're talking about eating disorders today and identity. I think I wrote down working with clients at the intersection of body image, eating disorders, and identity, November 2021. Trust the process. All right, so I want to make sure I put that in there so anybody who's watching the recording later knows what we're talking about.
Right.
All right, thank you for bringing that up. And it's interesting, one of the people who sat on my dissertation committee, because my dissertation was on this topic too, in part, talked about how I may have had very different results if I had run my study in specifically Los Angeles versus in the Midwest. It might have been different. Still would have found, results, but those results might have looked a little bit different in a different location.
I'm almost certain that they would have, because like I said, notice how I said it was a cultural thing within the school. Like, I'm telling you all, the same way people would go take a shower after gym class, this was kind of like the norm. It was like one by one. And like I said, had I not been paying attention, I may not have noticed it, but I was like, why is everybody going to this one bathroom? It just, it still intrigues me to this day. But I think too, just as a person who grew up in LA, everybody is so fascinated with celebrities. And don't get me wrong, there are some that I do think are wonderful people. They really are making an impact in the world. But I think that unfortunately, some create this image of what seems like is okay. And so many young girls feel like they have to be what this image is instead of just trying to be who they are.
Exactly. So I think that goes through, it's funny, we'll talk about this more at the end, so I'll bring it up so that you know what we're going to cover a little bit, Jill. When we look at culture, we look at race, we look at ethnicity, we look at sexual orientation, we look at gender, often situations are created where a person might feel like they are being attacked, unsupported, or need help, which means coping is necessary in reaction to one of those things. Eating disorders, as was brought up earlier, used to be conceptualized as something that only Barbie had. And by Barbie, I mean like the thin, able-bodied, rich, white, blonde, pretty woman. And while that can be something that faces that particular person too, eating disorders can affect any person who needs to cope with anything. And given all of the challenges that we face, no matter what our identity happens to be, it often requires some level of coping to navigate your world. So if I have to cope with all of these awful things or challenging things that present themselves in the world, if one of the ways in which people cope is through their eating and through their body image, why would I not, because of my race, because of my culture, because of my orientation, because of my sex, not be susceptible to those pressures and to need a coping skill as well? Does that make sense?
It does. Thank you, everyone, so much for the opportunity. I do have to run. We have a service, unfortunately, to get to. So I just wanted to say nice to meet everyone. Dr. Rush Wilson and Dr. Bohrer, thank you again for the opportunity. And I will be in touch with you ladies on the next one.
Thank you so much.
Thank you. See you all later.
See you later. So Britt, anything to add about identity?
Yeah. Well, I guess this is not necessarily specifically related to identity, but I wanted to point something out. And we kind of alluded to this earlier in that The eating disorder diagnostic criteria themselves were created based on these samples that Dr. Rush Wilson described, which are the thin, white, blonde, affluent, cisgender, straight women, which understandably leaves out a large part of the population who also have eating disorders that may not present in the same way. And so for me, it's just, I think about it like we have these diagnostic criteria that describe a very specific subset of people. There's no wonder that the most common eating disorder diagnosis is the other specified, which essentially means it just doesn't fit anorexia nervosa, bulimia nervosa, or binge eating disorder, because those criteria are only meant to describe a specific subset of people. And it doesn't mean that other people don't have eating disorders. And I recently have been getting more involved with boys and men with eating disorders literature and advocacy. And I recently wrote a book chapter about diagnosing eating disorders in boys and men. And I mean, the diagnostic criteria themselves are female centric. For anorexia nervosa, you used to have to have amenorrhea, which is the absence of menses. Well, if you're a man, you don't get a period, right? So just by definition, you couldn't have anorexia nervosa. It's just when we create these criteria for a specific subset of people, there's no wonder that it doesn't apply to the larger population. And it doesn't mean that those people don't have these problems too.
What it can mean, however, is that the people who don't fit into the normal eating disorder category don't seek help because there's something clearly wrong with me. If this is not something that people like me, however I happen to identify, if people like me don't have this, then I'm not going to tell anybody I do, because that means there really is something super duper wrong with me instead of just super wrong. So I just won't say anything. And what we have seen in the literature is that over time, people who are other eating disorder sufferers are much more severe in their presentation by the time they seek help, because they've gone for so much longer without seeking support. Because people like them, whatever that means for this person, don't have eating disorders.
And the other side of that is that providers, especially non-eating disorder specific providers, are not looking for other types of presentations. And so these eating disorders go unnoticed by these providers that, I mean, by their profession, they're supposed to be identifying and referring and treating these problems, and they're just not picking up on them. And I think that there's a lot of biases that go into that, you know, oh, people of color don't have eating disorders, so whatever you have must be something else, you know. That just validates the misconception of you know, oh, what I have isn't an eating disorder, it's something else.
There was a study, do I have it on my, I tried to go back and keep all of the old articles I found from my dissertation. I think I have a lot of them in print somewhere. I don't know where that box is, but there was one study that really intrigued me, and I'm pretty sure the author's name was it wasn't Root. I'll figure out the author's name before we get off the call, because it was either Root or Gold. But anyway, what they did was they went into a college undergraduate classroom of, let's say, 300 people, because that'll just make an easy number for me to manipulate. And they divided it into 3 sections, and they gave each section a different presentation. And one was about a Black girl, one was a Latina girl, one was a white girl. Everything else was the same. So they control for everything but that race ethnicity variable. And the person had an eating disorder, and they got 3 different diagnoses overall. So one had a substance use issue, one was poor and starving, the other had an eating disorder. The girl who was white had an eating disorder. And that illustrated what happens sometimes even in like hospitals. So when this person presents to a physician, that physician's preconceived notion, unless they know to ask specific questions, guides what they believe they're seeing with their clients, not because they're attempting to be biased, it's just happening. And if that bias goes unchecked, this person goes untreated. It's a big deal for us in any kind of healthcare profession, for physicians, for dentists. Dentists miss a lot of eating disorders, despite the fact that there might be some dental erosion. If they're not looking for it, if they don't suspect that this particular client, let's say this person is an NBA player, they're not thinking about this NBA player necessarily having like bulimia or nervosa. Why would I think those things, except it could be. Working with pro athletes who are male, I know that it can be. That happens sometimes. But if we aren't open to the entire array of possibilities with the people who come in for treatment from us, then we will miss things. And the nature of eating disorders is really not to be totally public with it. So sometimes our clients will keep that information back because they don't want you to know yet. So we've talked about race identity, race, ethnicity, and culture. What about sexual orientation? How might that be a thing with eating disorders? Why does that matter?
You're asking me?
Anybody who wants to come on in. I couldn't tell if Melanie was raising her hand or not. I saw some hand movement going on there.
Well, I can make a statement. I know that in working with some clients who are, not heterosexual, like for instance, a lesbian client might want to look more androgynous and maybe have an eating disorder to keep their body less feminine, right? To like have smaller breasts, smaller body, de-emphasize those parts of their body and feel, that their partner may not find them attractive.
Thank you much. All right, so Britt, what were you going to say?
I run our specialty diversity programming groups at our center. And right now, I would say most diverse identities that are in the group are of racial or ethnic diversity. However, historically, there's been a lot of LGBTQIA plus individuals. And to me, it's fascinating in a concerning way to hear about the ways in which eating disorders really thrive in the gay male community, and that there's incredible pressure to look a certain way. It's the whole like being very lean but muscular, and just the lengths that people go to achieve that physique, and how eating disorders thrive if the person's body just is, that's not what the body is meant to do, or maybe it's not possible to achieve that. And so that's something that really comes to mind for me. Something else that I'm really interested in that I haven't quite wrapped my mind around yet is that there's data recently to suggest that bisexual women have the highest rates of disordered eating. And no one has really been able to like definitively say why that is. But as a bisexual woman, it's really interesting to me, just because, I mean, there's, discrimination within the gay community, especially when we think about intersectionality. So people of color who identify as, non-heterosexual, that's a whole layer of variables to consider in the development of eating disorders.
Any thoughts? Any surprises? No? So what about men and eating disorders? Because I'm seeing a pattern here that I hope that we can exploit a little bit at the end. Men and eating disorders. Do men have eating disorders? Only men with mouths. So yes, if you have a mouth, again, you can have an eating disorder. Not every man, of course, not even most people necessarily have eating disorders, although the eating patterns in the United States and even sometimes in Canada can lead you to wonder what it is that you're seeing over time. But men don't have a clear path for treatment for eating disorders. For instance, there was a man I treated once, and when it was time to hospitalize him, we didn't really know where to go because they don't often have beds for men in eating disorder sites. The beds are all for women and girls. So where do you put this man? And then you have this man that you house separately. So now he feels othered even within the treatment facility because he can't be housed with a 12-year-old girl. And I understand that piece. This man understood it as well, but it was still kind of a, wow, I'm not even normal within this diagnostic group. So there are lots of things that go on there. This last example I'll give about men, and then Britt, feel free to jump in too. My district, well, one of my faculty members when I was writing my dissertation is a Black man. I was going to say he was, I bet he still is a Black man. And he was talking about going to get his haircut at the barbershop and how one of the other men talked about how sometimes after he ate, he threw up his food because it just really made him for lack of a better term, anxious to keep that food down. And my professor said it was so quiet for a few minutes, you could actually hear like the hair hit the floor. And then somebody changed the subject and they moved on, and nobody addressed that guy. And I've wondered about him for the years that I've been out of school. Like, what was that like for that man who got up the nerve to talk about this really like personal thing in this space? People heard it, didn't know what to do with it, and dismissed it and acted like nothing happened. What was that like for that guy on that walk or ride home? What happened to him? But there's no understanding, there's no foundation for many people to have a grasp on eating disorders at all. Nevertheless, an eating disorders in a Black person and then eating disorders in a Black man, where do you get that from? And then just keep it moving. What about you, Britt? Experiences with male clients?
I'm thinking of, well, I actually, at this higher level of care, have not had a man on my caseload. I tend to work with pretty complex, like BPD, substance use, gender or racial or sexual orientation minority patients. So no personal experiences with being the direct provider. However, something that comes to mind when I think of treating eating disorders in men, I'm jumping from the idea that they don't come to treatment centers as often just because of all of the barriers that you alluded to. They're just not identified and it's not talked about in male circles. But what I'm thinking of is how when men do show up, right, we're treating the eating disorder, we're treating the symptoms, we're treating the experience and building the coping skills to be able to not engage in these behaviors. And we're not treating the gender or the sex of the person, right? And so one idea that I've thrown out there to some of the experts in the male special interest group for AED is just more information about how to adapt existing treatment centers. How to adapt existing treatment centers to be more welcoming for men, not necessarily changing the treatment that we're providing, but changing, the language that we're using and the way that we're relating to them and the programming that we're offering and things like that. Because I do remember that we had one man in particular recently who was like, I feel so alienated here. And like a lot of the things that we're talking about don't apply to me. Like, I don't care what size my hips are. Like, it just doesn't apply to me. And so, when they do show up in these female-centric treatment centers, they are a minority usually because, right now we have one male, and I think we have 40 patients in our census. So, they are alienated, I would imagine, and feel like, nobody gets me. And then the other issue too is we don't have any male providers on our team, or we have one male dietitian. So, the people that they're talking to as well, I have to talk to this about women here, and they might not get my experience.
And that is important. We know that people tend to do better when they feel like they have some connection to their clinician, whatever that connection happens to be. So it might be by sex, by race, by age, by geographic location, by back, whatever it is. But you want somebody to feel like they've got some kind of connection to their clinician. In work with eating disorders, I think that's magnified. And Britt, let me know if you think so too, because we're talking about something really personal. I am actively and purposefully doing something that most people think is abnormal. And I'm going to tell you about it. And you might think I'm weird or abnormal or crazy or sick or whatever you think, but I can't get help without telling you. So I'm going to trust in you something super duper personal. And I need to feel like I am connected to you and that you get me in some way. In some way. It might be something that seems small. It might be something that might be pretty significant, but I need to feel like you have humanized me in some way. And if that's not there, it makes it much more difficult to treat. Plus, we've got a biological factor to consider. Repeatedly binging, purging, restricting, doing the things that come along with disordered eating necessarily has an impact on how we function. on our emotions, on our mood, and on our physical health. So imagine all of these things going on for just the normal eating disorder patient. And now on top of that, we have this person who is male where nobody else is. It's a very challenging thing for that client. Although it's funny, my very first client with an eating disorder was a man with anorexia nervosa, which I think a man in his 40s with anorexia nervosa. So he had all kinds of other things going on. What about age? Does age matter? Do we get over eating disorders by the time we're 25? Can someone's eating disorder start when they're 62? Do we ever see those people?
I'm really very happy right now. We have probably 5 individuals over the age of 50 in our treatment center, and usually our patients are like 19, right? We have one woman who is from the Detroit area, a Black woman, and it was so heartwarming. She wrote on her sheet this week, something I'd like the treatment team to know. And she said, I have never envisioned that I could be doing as well as I am today. And I am so grateful for this. She has binged and purged every single day since she was 14, and she's 56.
Yeah.
So these things go unnoticed and they go undiagnosed, or, maybe the person's able to say, it's not as big of a deal as it is. And eating disorders most of the time without intervention just continue thriving. And maybe they're not, full-blown severity the person's whole life. They might come and go, and they really do stick around.
Yes. Congratulations to her. That's awesome.
She's just, I have such positive judgments of her.
Yeah.
She's worked really hard.
Yeah, that's imagine going for decades of your life doing this one thing, and then at some point making a change. That's a significant undertaking. So good for her. It's pretty awesome. Lost my train of thought there. Oh, with eating disorder treatment and age, one of the things to keep in mind is, yes, we have a tendency to have people who might have repeated patterns in many, many years of sustained disorder eating behavior if they are in their 40s, 50s, 60s, 70s, 80s with disorder eating patterns when they present to treatment. So that is something to keep in mind. We also have to keep in mind their definitions of masculinity, of femininity, of aging, and how those things impact the changes in bodies that just happen. There's a website called Something Fishy, and they used to have a section, I don't know if they still do, I haven't looked lately, called They Said What? And it was about the odd things that eating disorder clinicians and treatment professionals say to people that make their eating disorders worse. So it was really like a subsection on iatrogenic harm. And one of the things that came up there is that amount of weight that fluctuates for people, sometimes for women in particular, and for men too, around hormonal changes. Sometimes those are natural but exaggerated changes. So a person might, change weight. They may gain a few pounds here or there, or the way that their body is shaped might differ to some extent. To highlight that might really have meaning for a person with disordered eating. It might mean that you now think that I am ugly, or I'm getting older, or I'm getting fat, and that that's a bad thing. When working with people, you have to be very careful to make sure you talk to them and understand their perspective and perceptions about their body and how it relates to the aging process. Makes sense? People used to believe that as you got older, you just gained weight naturally. That doesn't have to be the case. It's more of a metabolic issue, but for many people, the weight gain is negligible. For some people, it might be significant. We have to find out what that means for people. Let's see. This is something that is pretty interesting. When someone presents for an eating disorder and they are a person who is not in their teens or 20s, they may actually have some shame associated with the disorder eating that is different from people of younger ages. Any idea why? No? Part of the reason might be that eating disorders are often thought of as a teenage problem. So here I am, I'm 55 years old, I'm 62 years old, I'm whatever age I happen to be, and I have this teenager problem and I can't fix it by myself, and I'm embarrassed. That could be a real thing. That is something that we have to help a person neutralize and explore so that we can let them know that a disordered eating presentation is not associated with any particular age. However, younger people whose parents may find out about their disordered eating may force them into treatment, may encourage them to go into treatment. That person might not have the same choices as an adult. An adult might have responsibilities. I have a client right now that I wish I could put into an IOP or an intensive outpatient program, but it messes with her work schedule. So while she really would like to get help, she really would like to continue having a home. And that's a real issue. How do we balance these two things? How can we find her a treatment facility that works around her fluctuating schedule? So she didn't have a 9-to-5 job, her schedule changes. How do we do that? One of the other things to consider too with age and eating disorders when people are paying for treatment themselves is there can be a financial barrier to disorder eating treatment. It's expensive. Somebody that was thinking about the bill one of my clients accrued with their eating disorder treatment was thinking that's like a 2-bedroom house. It's a lot of money that her family ended up spending in insurance when all was said and done. It was incredibly expensive because she was in an inpatient facility. It's a lot of money. Not everybody has that, I guess, luxury, we'll call it, even though the insurance kicked in a huge chunk of it. That she had insurance alone was a luxury. I see that we only have a few minutes left, so this is what I'm going to do. I'm going to jump in and tell you just one story about one of my clients that impressed me. But if you have any stories you'd like to share, and then we'll take any questions that are left over. I worked with a client once who has a parent who, her parent was engaged to a famous person. Person didn't live in Ohio, but mom would fly back and forth to be with this person. And the more significantly absent mom was, and this kid was 17 years old, so it wasn't like she was, you know, a little baby, but the more often mom was gone, the more significant the disordered eating became for the client, and her weight was dropping at a rate that was really scary. It was time for hospitalization talk. But the thing about this kid was that she was an African, well, she still is an African-American, now she's an adult woman or girl who came from relative affluence now, but had been raised in poverty as a child. So there was a situation that changed their financial status significantly. And I used to wonder if she still lived here, would people pick this up differently? Now she's living here. And the assumption is that because of vanity and she wants to be around these types of people, blah, 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 she's just losing weight. But this kid was like size 12, size 10, size 8, and it was happening so incredibly rapidly. Her mom wasn't noticing, in part because I think mom might have been a little distracted by her relationship. And in part because, you know, she's looking good. They're reinforcing this girl's weight loss. You look really good. Those jeans look great on you. You know, that shirt looks really nice. And I like how it kind of looks like a model's body on you while you're walking. And they're reinforcing it. The more they reinforced her weight loss, the worse it got because she's being accepted. And at core, my belief is that eating disorders are about coping and about acceptance. I want to be good enough. And if I can be good enough by being thinner and smaller and reducing my weight, then that's what I'm going to do. It doesn't even really cost me much unless I'm using diet pills or gyms or something it costs. I can restrict my eating. And once I get past the pain of the starvation initially, I'm okay. Not okay. She had to ultimately be hospitalized. Thank goodness she survived, but she was really sick. My sickest client was 5'7", and what was she? 78 pounds was her lowest weight at 5'7". It's very, very low. And she's now a physician, which is on some level kind of funny to me. Even with her, we've kind of laughed about like, wow, you picked a profession that prevents your eating disorder because anytime your weight goes down too much, everybody you work with notices. The physicians, the nurses, everybody notices that something's going on and that pressure of having to explain yourself is too much. So she keeps
Maybe she did it purposely, no?
I'm good with that. That's a real expensive way to treat your eating disorder because medical school is not the cheapest route, but if it works, it works. The other thing with her too is that she was afraid she wouldn't be able to have children. She didn't want to have children. And one of the consequences of not having a menstrual period, if amenorrhea is a part of your anorexia presentation, is you can't have kids, or you are very, very unlikely to be able to have kids during that time. Any standout clients for you, Britt?
I mean, I think almost every single patient I've worked with really fits with what you said about eating disorders being about coping, oftentimes with painful emotions. You know, you can kind of think of it like, for people who engage in binge purge cycles, it kind of works like self-harm. Like the emotion's too high, I binge, I purge, and the emotion's gone temporarily, and then it comes back and you're stuck in this cycle. And similarly with restricting, I have patients who say, you know, they've really worked hard to get rid of all of their other behaviors. They're not binging, they're not purging, but the restriction is really sticking. And they're like, this is the last thing I have that numbs my emotions. And the emotions are too much for me to handle. I have to hold on to this.
Yes.
So for me, it really is about coping and emotions and, you know, learning other ways to maneuver your world that aren't going to lead to a grave.
Absolutely. Thank you for joining us today. Are there any questions that any of you have? No questions? We're all good? Domingo, you were completely silent. You have any questions?
No, ma'am.
Okay, thank you much. Want to make sure you had some space here too. Well, I thank you all for joining us. Next month, we're actually talking about immigration and counseling. So if anybody wants to join us, and feel free, Britt, to pop back in if you'd like to. So I thank you for your time on this Saturday afternoon. This video will be available to you, and I will also send you a link, Britt, if you'd like to see the second half that was actually recorded, and go from there. So if there are no other questions, I thank you so much for your time, and
Thank you.
enjoy your Saturday. You're welcome. See you next month, hopefully.
Thank you so much.
Yes. And Britt, if you can hang up for just a second, I'll stop the recording.